My name is Patricia Resick. I'm a professor of psychiatry and behavioral sciences at Duke University Medical Center.
Thank you very much and welcome to Australia.
Thank you.
You talked about cognitive processing therapy, and
Yes.
It was pretty much a masterclass in how it works. What are your key messages you're trying to get across here?
I think the key message in any big conference is if people are not working in the field of PTSD, they don't know that there are treatments that work for PTSD, and they're not years, they're a matter of weeks. And that I think of PTSD as an easily treated disorder, but I think it takes some skill to learn to do the protocols properly and to stick to them. Very often therapists take it and they put their own spin on it, or they go off and ramble off in some other direction, and then it isn't CPT or prolonged exposure anymore. It's something else entirely. And then
Why do they do that?
I think because some people think that therapy is an art and not a science. And I think it is a science, and we're learning that. I mean, we've already studied and know that if you stick to the protocol, it works better. And if the clients are not doing their practice assignments, you've got to get them to do their practice assignments, because if they do their practice assignments, it's going to have a better result. So they can't just let things slide.
Can you go through first the protocols and then the fact that you've actually looked long term now at how it works?
Right. Well, and with reference to cognitive processing therapy, or CPT, we've studied all the way out to 5 to 10 years post-treatment and don't see relapse, even when people have had other traumas happen to them. And they typically, about 59% got other treatments, but it wasn't for the thing they came into us for. And so that means they probably had a good experience. So if their child is diagnosed with something, they know to go to therapy, and they're more willing to go to therapy. If they get a divorce, they're more likely to go to therapy afterwards. And so we were finding that even long term, it didn't mean they never got therapy again, but they got therapy for other things.
What are the tools involved in CPT?
Well, it's actually very much a therapy that we try to hand to the client so that we're not doing the work. They have to figure it out. We can't convince them it's not their fault that the trauma happened. They have to figure that out, and we use a series of worksheets. We have them start with an essay where they have to write about why they think the worst traumatic event happened, and we'll start with the worst rather than some lesser trauma, because we find a downward improvement with other traumas that weren't quite so traumatic. But they'll write an essay on why they think it happened and how it's affected their life in terms of their feelings about themselves and their thoughts about themselves and others. And then we start teaching them systematically how to become their own cognitive therapist. What's the difference between an event and a thought? And if they have a thought, what feeling do they have? If they change their thought, do they feel differently? And then we start teaching them systematically how to pick out the things that have kept them stuck in their PTSD and why they haven't recovered, which is sometimes the if only I had done this, to trying to go back and undo it after the fact. Or trying to keep their old belief that the world is controllable, and that if they just figure out what they did wrong, they can somehow change things so that bad things will never happen again. They don't accept what the rest of us eventually have to accept, is that bad things can happen, and we only have two choices, which is coping or not coping.
This is, with therapy like this, what is its role in reducing the medicalisation, really, of trauma and mental illness?
Well, there is no medication for PTSD. And they use SSRIs, the depressive medications, but I think that's mostly affecting the overlap symptoms and the fact that about 50% of people with PTSD have major depressive disorder. But if you take somebody off the medication, they're not going to be better.
But you did talk about how if you treat depression first before you treat PTSD, that doesn't work.
They're likely to relapse, and it doesn't fix the PTSD. But if we treat the PTSD first, then we see a decrease in their depression symptoms.
Now, you talked also that US prisons, and I would wager Australian ones, are filled with people with PTSD. So
Yep.
what are the broader public health implications of the work that you do, and what should be done?
Well, I think we need to understand when somebody is aggressive or commits a crime or gets into, in our country, sometimes people can be very harshly punished for drug offenses and so forth, and that might have been PTSD avoidance. They were self-medicating, or because they have a lot of anger. You know, if you have a fight-flight response, people who have fear are going to flee, but the people who've been trained like soldiers to fight are going to go forward and have a very strong anger response. They assault somebody when they get home, they're in prison. So I think we need to think about diversion programs where they can get treatment instead of punishment. And I think if they are in prison, they need to, if they're going to get out, we want to get the PTSD under control so that they can come out and have a more productive life.
Where else is PTSD too hidden or untreated?
I think it's a problem. I think it's a problem as much for the patients as it is for therapists who don't know about that there are effective treatments and that they're not long-term treatments. We can do it fairly quickly. But I think the other problem is getting people who have PTSD to come to treatment. There's such a stigma about getting mental health treatment. So I think we have to work very hard to help people overcome that stigma and think sometimes events in life are too big to handle alone, and it's okay to get help.
Thank you very much. Any other words for a public health audience in Australia?
I think basically just understand. I think on a broad scale, understanding not everyone gets PTSD, but among those who do, it can be a lifetime problem if they don't get help, if they continue to avoid and so forth. And so we need to have a better referral system, and we need to get more people trained. A lot of the work I'm doing now is on dissemination of therapists learning how to do these evidence-based treatments.
Fantastic. Thank you very much.
Sure.